Hi, everybody. For those of you that don't know me, the interns, my name is Jigna, and I'm one of the third-year PEM Fellows. And today I'm going to give a lecture on neonatal resuscitation. All right. So we're going to go over a few different things today. First, we're just going to review like the fetal and newborn physiology, some of the risk factors that'll make newborns more likely to, need resuscitation, recognizing some of the signs and symptoms of distress. And then we'll go through like the NRP algorithm. And then we'll talk about some of the medications and equipment and some ethical principles. And if we have time, we'll go over a case scenario together. All right, so which babies require resuscitation? Most newborn babies are actually born pretty vigorous and don't need resuscitation. Only about 10% require some sort of assistance to begin breathing at birth. Only 1% really need like extensive resuscitative measures, such as intubation, chest compressions, and even medications to survive. In the fetus, so in order to understand some of the causes of distress in newborns, it's important to first understand some of the basic principles and their fetal physiology at birth. So the alveoli, which is their potential air sacs of the fetus, are usually filled with fluid, which is produced in the lungs. And the oxygen is usually transferred via the placenta when they're in utero. Blood flow through the fetal lung is usually markedly diminished initially compared to what's required after birth, as the pulmonary arterioles are constricted and the blood flow is actually diverted through the ductus arteriosus, and this is all in utero. So at birth, what happens is as the newborn takes their first breath, there's a lot of changes that occur like simultaneously at the same time. So following birth, what happens is the lungs start to expand and they start to fill with air. And as this happens, the fluid starts to gradually be absorbed from the alveoli. At the same time that the lungs are expanding and the fluid is clearing the arterioles, the lungs start to open up because previously they were constricted because they weren't getting blood supply. And then the amount of blood flow actually to the lungs increase. So as you can see, I don't know if my marker works here. Okay, so this is like in utero, you see like the vessels are really constricted because there's not really blood flow and oxygenation happening in the lungs. But after birth, as air fills and oxygen enters the alveoli, the arterioles start to dilate. So as the pulmonary blood flow increases, the blood level of oxygen rise and the ductus arteriosus then begins to constrict. The blood is diverted, that previously was diverted through the ductus arteriosus, now actually flows through the lungs where it picks up oxygen and transports it throughout the body. The ductus arteriosus remains constricted and the normal extrauterine respiratory and circulatory patterns are then established. I know this is a lot of embryology that we learned in medical school, so just a little recap. So normally there's three major changes that occur all within seconds at the same time. So the alveoli, the alveolar fluid is absorbed in the lung tissue and is replaced by air. The umbilical arteries and the veins are clamped, removing like the low resistance placental circuit and increasing the systemic blood pressure or vascular resistance. And the blood vessels in the tissues start to relax, and this is what causes the increased pulmonary blood flow. So this happens literally in seconds. Okay, so a baby can encounter like multiple difficulties before labor, during labor, and even after labor. Some of the problems that can occur that disrupt the normal transition are the baby not being able to breathe sufficiently to force the fluid out of the alveoli, or foreign materials such as meconium being in the alveoli and preventing air from actually entering. There can be excessive blood loss during delivery, or there can be inadequate cardiac contractility or bradycardia, which results from like hypoxemia or ischemia. Also, there can be lack of oxygen or ventilation of the newborn's lungs, resulting in a sustained constriction of the pulmonary arterioles, which prevents the pulmonary blood from becoming oxygenated. And lastly, it's the prolonged lack of adequate perfusion and oxygenation to the baby's organs can lead to brain damage, damage to other organs, or even death. There's a lot of different risk factors that place babies at risk for requiring resuscitation. There's maternal risk factors, fetal risk factors, things that can happen antepartum, and also complications during delivery. So some of the maternal risk factors are being advanced maternal age, so being more than 35, or being really young as well too, so like the young teenagers, having diabetes or hypertension, having a substance use disorder, or even a history of stillbirth, fetal loss, or early neonatal death. Some of the fetal complications can be prematurity or post-maturity, and we'll talk about prematurity in a second. They can have congenital anomalies, which can make it difficult, intrauterine growth restriction, or multiple gestation. Some of the antepartum complications can be like placental anomalies such as placenta previa or abruption, oligo or polyhydramnios, or delivery complications such as the transverse or breech lie. They can also have chorioamnitis, meconium-stained fluid, or even have antenatal asphyxia. Did I skip a slide? No, okay. So prematurity makes preterm infants more likely to require resuscitation and actually develop complications. Majority of the cases actually need resuscitation. Some of the risk factors are hypothermia because they have a larger body surface area to the mass and to their mass, and their skin is really thin, and they have decreased subcutaneous fat. So this makes them at risk of becoming hypothermic. Generally, the smaller the infant, the more difficult it is to prevent hypothermia. I don't know if you guys have ever, like those that have rotated through the NICU, you've probably seen the really, really preemie babies. They like wrap them in saran wrap and try to warm them as soon as possible after birth. Other things in prematurity that make them at risk is inadequate ventilation because they have a deficiency in surfactant, which makes it difficult to actually inflate and ventilate the lungs. They also have an immature respiratory drive and weak respiratory muscles, which increase their risk of apnea and resulting in inadequate respiratory support. They also have immature respiratory or immune systems, which make them prone to infections, and immature organs and capillaries, which make them prone to bleeding. So basically, preemies, you have to be a little bit more precautious. Okay, so what do you do in preparation to birth? So at county, I know they usually call a code 54 if there's like a note that comes in that there's a mom that's about to deliver. Just know this hospital specific code for where you're working at. It's not going to be the same everywhere you go. So if they call a code saying that there's a mom on the way who's about to deliver, these are the things that you basically should do to prepare for it, because a lot of things are going to be happening simultaneously, and you want to make sure that you have everything ready for the child just in case they might need further resuscitative efforts. So call the code. Inform the NICU if you have them available, because they are the experts when it comes to this. There's only certain things that we can do and that we're knowledgeable about, and we don't do this often. So having the specialty team available is really helpful. Turn on the radiant warmer, have it already pre-warming, get warm blankets and have them readily available, have the suction apparatus in place, have this, I usually have the mechanical suction plugged in, plus have a bulb suction on the warmer, like ready to go. Have umbilical cord clamp there as well too, because you don't want them to like continue bleeding out. And also, most importantly, have your oxygen source available and plugged in, and make sure there's adequate flow through the tubing. I generally like make sure that not only is like the PPV ready, but you just have at least like blow by oxygen, like a cannula just plugged into the wall, running at 100%. Also make sure that you have the appropriate size face mask and BVM available for the preemies. Usually everything, there's like a BVM bag hung like on the radiant warmer. So everything should be under it, but just whenever you go in, just, check out the radiant warmer, see what's there, see what's not available, so you kind of know. And then lastly, you want to make sure that you have your intubation supplies readily available. So the correct size laryngoscope, ET tube, and stylets as well. So immediately after birth, there's a few questions that you want to ask and you want to have answered. So you want to know, is the baby term gestation? This will tell you if they're going to need resuscitative efforts or not, or if they're going to be at risk for needing them. You want to know if the amniotic fluid is clear versus if it's meconium stained. And then you want to know if they're breathing or crying versus are they gasping or apneic. And you want to know their muscle tone as well too. If the answer to all of your initial questions are yes, and it's a term newborn, then the newborn can usually stay with the mom and just receive routine newborn care and continue transition. But if the answer to any of these questions are no, then it's likely that they're going to require some sort of resuscitation. So a compromised baby or like signs of a compromised newborn. There's a bunch of them. They can have poor muscle tone. They can be limp or floppy. They can have a depressed respiratory drive or insufficient oxygen reaching their brain, so they could be gasping or they could be apneic or even taking shallow breaths. You may see bradycardia. You may notice a really low blood pressure. You may notice tachypnea or rapid respirations or even cyanosis. And it's important to recognize the different types of cyanosis, whether it's central or if it's just peripheral. So as you can see in this picture, you see a baby that has cyanosis but has good tone. He's crying, he's moving, or she. And in this picture, you see also a baby with cyanosis, but they're kind of just limp and floppy. So that baby is definitely going to require some sort of resuscitation. So you don't have to memorize this chart. The NRP chart is actually, you can look it up on Google, type in NRP 8th edition, and it pops up right away. And I love this chart because it's just like when you resuscitate adults or children, like following PALS or ACLS, you just follow the algorithm, which is great. Literally just go step by step. It also has all of the corrective steps for ventilation on there, as well as sizing for ET tubes and the depth, as well as medication dosing, depending on the weight or the gestational age of the child. Okay, so we're gonna go through all of the ABCs of NRP. This is just like a quick preview of it. Any questions so far? Okay. All right, so these are the initial steps that you should take to establish airway and begin resuscitation in a newborn. So the first thing that you wanna do after, the first thing you wanna do after you ask like the main questions, is it term gestation? Do they have good tone? Are they breathing or crying? Is down here. So follow the algorithm. So you provide them warm. So bring them to the warmer, dry them with like warm blankets, wipe them off, and then stimulate them. Drying them is really important because they have a lot of fluid on them when they're born initially, and that's going to increase their risk of hypothermia. So you want to dry them really, really well, and then provide them with warmth. Stimulate them. You can do this by rubbing the back. I sometimes flick the soles of their feet to get them to start moving around and crying. And then you want to position the airway in a good like sniffing position, which I'll show you in the upcoming slides. And if needed, you might need to suction the airway. So you can either use a bulb syringe or you can use a suction catheter. Always remember that you should suction the mouth first and then the nose. So just really quickly. So if they have good tone, term gestation, they're breathing and crying, they could just stay with the mother and get routine care. But if any of these are not good or the answer is no, then bring them to the warmer and follow these initial steps. So what do you do if meconium is present? So if the newborn is vigorous, moving around, has good tone, suction the mouth and the nose, and then just proceed with the rest of the resuscitation steps. If the newborn is not vigorous, then you will probably have to suction the baby a little bit. You might have to stimulate the baby. And if they're not responding, they may also need some PPV, which is basically positive pressure ventilation. This is the correct way that you put the baby in sniffing position. So you see how the airway is aligned completely straight. Their chin is aligned with their chest. You don't want to hyper extend them or hyper flex them because then the airway is not going to be completely aligned and you're not going to provide adequate ventilation to them. So after the initial steps, there's three things that you want to check. You want to check their respiration, see if they're still breathing, are they still gasping versus are they crying and have good tone. You want to check their heart rate and make sure it's adequate. And then you want to check their color. All of this together should, in general, take about 30 seconds. If they're not breathing or their heart rate is less than 100, then you want to continue to move down the algorithm. These are just some pictures I wanted to show you guys. So this one shows central cyanosis, which is basically caused by too little oxygen and blood, which causes like blueness to like their tongue, their lips, and also to their central trunk, versus acrocyanosis, which is actually relatively common in newborn infants, where they just have like blueness of like their hands and their feet, but you'll see their trunk and their face and everything is nice and pink. I know you guys have all heard about Apgar scores. Just, familiarize yourselves with them again. You can, if you don't remember them, you can easily pull it up again on Google. Apgar scores basically are great because they tell you how responsive the child is and whether, they're going to need some sort of resuscitative effort. You usually want to do an Apgar score at 1 minute and then again at 5 minutes. I can go through it really quickly. So A stands for appearance. And skin color. So based on if they're pink or blue, you assign a score. P stands for pulse. So you're looking for a pulse like more than 100 versus less than 100 or absent. G is grimace, or how their reflexes are. So if they're floppy versus if they're responsive to stimulation or minimally responsive. A is activity, or their muscle tone. So do they have zero muscle tone versus are they active and moving around? Or are they just like their arms and legs just flex, but they're not really moving? And then R stands for respiration. Are they crying vigorously versus is it a slow, weak cry, or are they not crying at all? All right. So I put just like the whole algorithm here. So now we're down to here. So if the baby is breathing and the heart rate is more than 100, but the baby's cyanotic, then you want to take some steps to, where am I? Okay. Yeah. So if the baby's breathing, like I said, and the heart rate's more than 100, but still a little bit cyanotic, then you want to take some steps to kind of fix their oxygenation. So reposition their airway, suction them, give them supplemental oxygen via blow-by, which I'll show you guys in a second. And if those don't work, then you may want to consider CPAP. And if the cyanosis is still persisting, they might need a little bit of PPE for like a few minutes or so. But if they're apneic or they're gasping, and their heart rate is less than 100, then they're probably going to need some positive pressure ventilation. And usually you want to do this for 30 seconds before reassessing them. So every 30 seconds, you should be reassessing them after giving them PPV. Start with 21% FiO2 and then increase as needed if you feel like they're not responding adequately. This is also on the NRP chart. So these are their ideal saturations after birth. So if your baby is like satting at 70% and it's been 3 minutes, don't freak out because that is their normal saturation and what they should be satting at that many minutes post-birth. So always refer to this chart to see like what their saturation should be after birth. Usually it takes about like 10 to 12 minutes for them to receive, to get to 100% oxygenation. And then the chart also tells you the initial oxygen concentration to start at for PPV, depending on their gestational age. So if it's more than 35, you want to start at 21%, versus if they're less than 35% or 35 weeks gestational age, then you can start a little bit higher at up to 30 even before increasing. So this is how you can give them blow-by oxygen or free flow oxygen. Usually you just connect the nasal cannula to the wall and then just hold it like over their nose and kind of cover the area so a lot of the oxygen doesn't escape. And that usually is sufficient in helping increasing their oxygen concentration. If you feel uncomfortable doing that or you don't have the right equipment, then you can just use like a face mask or an oxygen mask and just put it over their nose. And that will help them as well too. There's two ways that you can give PPV. You can use like a self-inflating BVM or use the T-piece resuscitator, which I'm used to using and we generally have available here. The T-piece resuscitator is a little bit better because it's giving natural CPAP, and then you can control the PPV or the positive pressure you give by occluding the hole at the top. So every time you occlude it, you're giving them like extra positive pressure. Um, like I said, you should make sure that you have the appropriate size mask. It should always cover the tip of the chin, the mouth, and to the nose. You want to make sure it's not bigger than their face because you don't want oxygen to escape, or too small because you want to make sure that they're getting adequate oxygenation as well too. You usually want to give for at least 40 to 60 breaths per minute to give them appropriate ventilation. And some of the signs of effective ventilation is improvement in heart rate, color, and muscle tone. You may also notice like improvement in their breathing and saturation as well too. All right, so this is what we've gone through so far in the algorithm. So if their heart rate was more than 100 and they were just a little cyanotic, then we gave them some blow-by, maybe some CPAP, and then reassess them. Versus if it's less than 100, we gave them PPV, and by this time, hopefully connected them to a cardiac monitor as well too, and then you reassess them every 30 seconds. All of this should take about a minute to do. I know it's a lot to do in a minute, but it happens very quickly in real time. So despite everything you did, if their heart rate is still less than 100, what should you do? You've given them PPV for 30 seconds. You want to make sure that you're giving them adequate ventilation, right? So you can follow the Mr. SOPA mnemonic, which we'll go over in a second. Also start preparing for intubation, so consider getting your laryngoscope, your ET tube, your stylet, and everything together while somebody else is like continuing to give them PPV and correcting their ventilatory measures. Connect them to a cardiac monitor as well too. If their heart rate improves and it's more than 100, then you can just, continue regular routine care and sign them out either to the nursery or to the NICU, depending on where they should be going. So these are the corrective measures. It's called Mr. SOPA. This is an old chart, but on the new NRP, they have this whole chart written there, which is great. So Mr. SOPA, so M stands for mask readjustment. So readjust the mask, make sure it's correctly covering the nose to the tip of the chin, reposition the airway and sniffing position, and then give them PPV for 30 seconds before reassessing them. If you see chest movement and improvement in their heart rate and their saturation, then you don't need to go on. But if you don't see an improvement, then you move on to S and O. So S stands for suctioning the mouth and the nose, and then opening the airway to make sure that they're getting enough oxygen through their mouth. So after you do S and O, you again do PPV for 30 seconds. Look for good chest rise. If it still hasn't helped, then you move on to the next steps, which is increasing the pressure. So we initially started at about 21 to 30% FiO2, but you can increase it more and see if that helps as well too. So give them PPV again for 30 seconds. If it helps, great. If not, then at this point, you probably need to intubate the baby. All right. So you confirm adequate ventilation with appropriate chest rise. Like I said, give PPV for 30 seconds and see if there's adequate chest rise. If after 30 seconds of PPV, the heart rate is now less than 60, then that means we need to start chest compressions on the baby. So you want to support their circulation by starting chest compressions while continuing the ventilation simultaneously. So giving them PPV and continuing chest compressions. Making sure that you should usually compress 1/3 of the AP diameter. The newborn at this point should be connected to a cardiac monitor. If not, get them on a monitor right away. And then if at 30 seconds later, they're still less than 60, then you need to intubate them. So intubate them, you can use the ET tube or you can use a laryngeal mask. or if you don't have those available, then just give them oxygen through BVM. Usually we give it, you do like 120, at least 120 compressions per minute. And every third compression, you give them a breath. So the way we do it is usually like breathe 2, 3, breathe 2, 3, breathe 2, 3, and you're continuing compressions. And every time you say you breathe, you give a breath. At the same time, you should be trying to get IV access on this baby. So umbilical access is probably the best and the easiest way to get it. Although, you know, we don't do it as often in the ER, so it's always good to kind of, stay up to date and recap yourself on how to do umbilical vein access. It's something we're going to practice today in procedure day, so hopefully, you guys can learn a little bit from there. If you're not able to do that, you can always do an IO access, or you can give medications through their ET tube if they're intubated as well too. So after 30 seconds of compressions, you want to evaluate the newborn again and check their heart rate. If it's still less than 60 beats per minute, then you move on to the next step and go down the algorithm, which will be, where's my marker? Which will be down here, which we'll talk about in a second. So how do you give chest compressions? Like I said, you want to make sure you're compressing at least 1/3 of the anterior posterior diameter. Make sure the baby's connected to a cardiac monitor at the same time. And then the compression should also always be accompanied by ventilation. So at the same time you're doing compressions, don't stop giving breaths to the baby. And at this point, they should be on 100% oxygen. There's 2 ways that you can give compressions to a neonate. You could do the thumb technique or the 2-finger technique. The thumb technique, I generally prefer it as well too. So you have your thumbs basically touching each other on the middle of the sternum while the rest of your fingers are encircling the chest. And then you just press down on the sternum every time you give a compression, versus you can do the 2-finger, just so holding like your middle and your index fingers together, pressing down on the center of the sternum, and always make sure, like I said, you're pressing down 1/3 of the diameter. If you're doing the 2-finger technique, always make sure your other hand is on the back, supporting the back. So if they're on like a bed that's not firm, you want to make sure that they're getting appropriate compressions and you're compressing the appropriate depth. Okay, so the compression ventilation cycle, like I said, the breathing rate is usually 30 breaths per minute, and they're getting about like 90 compressions in a minute. You could do more as well too. So breathe 2, 3, breathe 2, 3. If you continue doing that, you'll get about 120 events in 1 minute, like breathing breaths plus compressions. Okay. So if you want to intubate the child, you want to intubate with the correct size ET tube or laryngeal mask, like I said, or you can use BVM if you don't have that available. You can refer to the NRP chart for the size of the ET tube based on their gestational age and the depth of insertion. So you don't have to really memorize this, but having a general idea is always good. All right. So the correct size usually of the laryngoscope, generally in preemies, it's 00 or 0, and in term infants, it's 0 or 1, depending on their weight and their size. Always make sure you check the light on the laryngoscope and have the suction readily available and plugged in. Usually we have the suction set to 80 to 100 millimeters mercury on the wall because you don't want to give too much pressure. We usually use a larger suction catheter, usually about 10 French, will be good to suction the nose as well as like the oral secretions. If they're going to be intubated, since likely at this point, if you're at this point, then you should also have like a smaller suction catheter available so you can suction the ET tube as well too if needed. So there's multiple ways that you can confirm that you have intubated the child correctly. If you have X-ray readily available, you can get an X-ray and make sure it's at the correct placement. Here you can see it's the right main stem intubation. Or the easiest way is listen to breath sounds or connect them to an end tidal CO2 and look for the correct numbers. So special indications for intubation is basically extreme prematurity. Those babies are going to need to be intubated right away. They're also going to need to be given surfactant right away. Hopefully the NICU's there at that time so they can tell you the dosing for that, or if you ever suspect a diaphragmatic hernia. So when to consider like a laryngeal mass. So sometimes you might not be able to intubate the child because they may have like a cleft palate or some or other sort of craniofacial anomaly. They may have like a small mandible or even a large protruding tongue, which would make the intubation very difficult. So it might be more beneficial to just use a laryngeal mask in those scenarios. There are limitations to using a laryngeal mask, though. It's hard to cut suction, especially if there is meconium around the mask. It's really unknown if it's effective when you're doing chest compressions or if you want to give like medications and you don't have access yet or umbilical vein access, then you might need to give them through an ET tube, which you can't do if you're using a laryngeal mask. And then you might not also be able to give like high pressures just because there might be some leakage around the mask. And if the baby's like really small or so very low birth weight, you might not even have like the appropriate size mass. So intubation might be like your only choice. So after 60 seconds of chest compressions and PPV, and you've intubated the child, you want to evaluate them again. If their heart rate is still less than 60, then at this time, they're going to need further intervention. So you're going to need to consider giving them medications as well too. You also want to consider some like alternative causes of why they may be like hypoxic or still have like cardiovascular compromise. So consider like hypovolemia. You may need to give them fluids as necessary, and also consider like a pneumothorax as well too. Again, the medication dosages are on the NRP chart based on their weight, and they have it divided into the IV dosing, versus the ET tube dosing. So if you're giving it through the ET tube, it's going to be slightly higher concentrations of medication versus if you're giving it IV or IO. And if you're going to give a saline bolus, it also has the dosages of the boluses as well too. Remember the epinephrine you can give every 3 to 5 minutes and continue reassessing them. All right, so medication administration. So umbilical vein is usually the preferred route for giving medication and getting IV access, but you can also use the ET tube or do an IO if you're having difficulty in getting access through the umbilical vein. Usually you want to use the 3.5 or 5 French catheter for getting umbilical vein access, and then always use like a sterile technique. So you usually insert the catheter anywhere from 2 to 4 centimeters, even less for preemies. And then you want to make sure you're getting a free flow of blood when you aspirate to make sure you're in the right position. Try to avoid pushing the catheter down too much because you don't want to enter the portal vein or get to the liver and cause damage there. And then hopefully the NICU's there at this time so they could do this for you. So calling them ahead of time is really helpful. So some of the indications for volume expansion. So if the baby's still not responding, despite your resuscitative measures, or the baby appears to be in shock. So if they're pale, have weak pulses, persistently low heart rate, they're not really improving despite all of the resuscitative measures, it might be a good idea to at least give them like a small bolus of normal saline. And then also look for if they have like a history of, blood loss or fetal blood loss. So if there was a lot of vaginal bleeding during birth, there was placental abruption or previa, or if they're twins, always think about twin-to-twin transfusion as well too. The recommended solution is generally normal saline, but you can use lactated ringers, or you can give ORH negative blood if needed. The dosing is a little bit less than what we give to our children. So the bolus for them is 10 cc's per kg. And like I said, the preferred route is umbilical vein, but if you can't, then you can use the other. You can do an IO. Always make sure you're drawing like the correct volume, like in a syringe, and you can just push it all at the same time. But give it over like 5 to 10 minutes. Some of the signs of improvement that you'll see is like increase in heart rate, their pulses will become stronger, their pallor will improve, their blood pressures will improve. But if the hypovolemia like still persists, then you can consider giving repeat saline boluses. So at this point, I think we've gone through all of the A, B, C, D, E's of neonatal resuscitation. Some of the ethical principles, just to kind of be aware of in newborns. It's not any different from children and adults as well too. It's just autonomy, beneficence, non-maleficence, and justice. They can't tell us these things or tell us like how they feel. So always just kind of keep these in mind. And then just kind of know your laws depending on where you're practicing because they are a little bit different. There's no federal law that really mandates resuscitation in all circumstances, and then withdrawal of support if resuscitation is deemed futile is appropriate. Based on like the available data right now, preemies that are born less than 22 weeks are generally not considered viable at most centers. I know at Kings County, they still resuscitate 20 weeks and older, or they at least try to. So just, be aware of what is practiced at your facility and in your state. And then it's always good to involve the parents, during these times, encourage them to kind of be around the child or hold the child if necessary, try to reduce or treat their pain if possible, and just be culture like sensitive to their cultural practices and spiritual needs. All right, any questions?